You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for Friday the 13th, April 13th, 2018. This week, post-cardiac surgery AF, long QT syndrome, exercise, a new risk factor for women, and TAVR. First topic today is post-cardiac surgery AF. I think I've said this before, but I don't think there ever will be a way to prevent AF after the heart is cut upon. So, we better figure out the best way to treat the problem once it occurs. And one of the most difficult questions I get when patients have post-cardiac surgery AFib is whether or not to use anticoagulation. It's an issue, of course, because of the risk of post-op bleeding. A cohort study published in JAMA Cardiology set out to inform this question. Authors from Denmark, along with a group from Duke, compared 2,100 patients with post-op AFib with about 8,000 matched controls that had non-valvular AFib. So matching allowed for comparing risk factors like CHADS VAS score, age, and sex. And the findings were provocative and interesting. So the risk of thromboembolic events was significantly reduced in patients who had post-cardiac AFib compared to those with non-valvular AFib. The hazard ratio was 0.67. So post-cardiac surgery AFib looked a lot less risky. All-cause mortality, too, was reduced in post-op AFib compared with non-valvular AFib. These lower rates of stroke also are comporting with previous database studies. But importantly, this study is observational, and so we need to be careful about interpretation. That said, post-op AFib is most often self-limited, and thus it's plausible that stroke rates should be lower. And I think this data argues for caution in the use of oral anticoagulants in these patients. There's no RC data showing that anticoagulation is beneficial in post-op AFib. And there is good RCT data from Gillenhoff et al. In the New England Journal of Medicine showing that more than 90% of the time the post-op AFib is gone at 6 weeks. And now we have observational data suggesting a lower stroke risk. I think this is important information to be considered in these patients. Second topic is long QT syndrome. And long QT syndrome really does scare doctors. And it's a serious disease in that it causes ventricular arrhythmias, but also because it causes doctors to be fearful. And I say that because when docs get scared, patients can be exposed to overtreatment. That's why I like a study from a well-known group in Pavia, Italy, led by Professor Silvia Priori. They have a registry study of more than 1,700 patients with long QT syndrome, and that provides a lot of useful knowledge. Journal American College of Cardiology, or JACC, published the article, and the study confirms a lot of what is already known. First, with the advent of gene testing, more and more people get diagnosed with concealed long QT. That means those without events and without a baseline prolonged QT interval on the ECG. But crucially, importantly, regardless of the gene phenotype, long QT 1, 2, or 3. This study shows a very tiny risk of events if the QT is less than or equal to 460 milliseconds. And this really tiny risk group comprised more than 40% of the cohort. So another observation of note was that the risk of ventricular arrhythmias parallels the QTC interval. The authors noted a 15% increased risk of events for each 10 millisecond increment in QTC interval, and that sort of gives you a spectrum of risk. Perhaps the most important observation pertains to beta blocker use. Two things. First, beta blockers did not increase the risk of events in patients with long QT3. Remember, long QT3 is the one type of long QT syndrome that associates with events when heart rates are low. So there has been this lingering concern that beta blockers might make things worse in long QT3. This was not found by the study authors. The second observation from this study was maybe even more important, and namely that nadolol seems to be the best beta blocker to use in long QT syndrome. By a lot, the hazard ratio was much better for nadolol. Now, nadolol is a non-selective beta blocker, meaning it blocks beta 1, beta 2, and beta 3 to comparable extents. Now, this could be important because blockade of only beta-1 receptors, like the selective beta blockers do, could allow upregulation of beta-2 receptors, and if that happens, cardiomyocytes may be more exposed to the arrhythmogenic effects of catecholamines. Also, the pharmacokinetics of nadolol may favor compliance with the drug, which is also critical in patients with long QT syndrome. For instance, nadolol, unlike propranolol, which is another non-selective beta blocker, does not cross the blood-brain barrier, and therefore there may be fewer CNS side effects with nadolol. So compliance is a big issue with beta blockade in long QT syndrome, because remember, if you're coming on and off beta blockers, you could be exposing patients to beta blocker withdrawal and actually high levels of arrhythmogenic susceptibility when patients are off beta blockers. Next topic is exercise. Now, the AHA, American Heart Association, has strengthened its stand on exercise. And this was a 33-page statement with 262 references, and in it, experts from the AHA doctors recommend exercise to their patients. And so strong that the authors feel they want to make physical activity a vital sign. So I love exercise. I recommend it every day that I'm in clinic, to the old, to the young, to those with chronic illnesses. But please, we don't need any more vital signs. Blood pressure, heart rate, respiratory rate, and temperature, these are fine vital signs. Look what making pain a vital sign did for us. Nothing good. I think we can spare journal space, and I can think of better uses of time than writing a long 260 referenced article hidden behind a paywall telling us to recommend exercise. On the matter of exercise, mastery of the obvious, I think, is mostly what is needed. I tell my patients to move every day that they eat. Movement every day is a good thing. Fourth topic, interesting new possible risk factor in women. So everyone agrees that there are important gender-related differences in cardiovascular disease. A well-done, large, and longitudinal cohort study published in Circulation suggests the possibility of another gender-related risk factor for women. That is, giving birth to an infant with a congenital heart defect. This was a longitudinal study, means it follows people over time. Here the authors started with over 1 million women who delivered infants between 1989 and 2013. The authors followed these women over the years and observed a higher rate of cardiovascular hospitalization in women who had a baby with a critical heart defect versus those with a normal infant. The adjusted hazard ratio was 1.43 with a confidence interval from 1.1 to 1.82. And adjusting for preeclampsia did not change the higher risk. The authors don't have an obvious plausible cause. They speculate on some, but one that they speculated on, and I agree with, is surely the added stress of having a baby with a serious congenital heart defect. And I'll speculate here, but based on my observations over the years in clinic, I think stress can have increasingly significant effects when chronic. We all understand acute stress like grief or trauma, but less appreciated is the effect of low-grade, constant stress. Anyways, this is an interesting observation and one that deserves more study. It's a nice paper. Final topic is on TAVR, and another TAVR complication is published. This one is called delayed coronary obstruction. It's an uncommon and barely reported complication after TAVR. So many authors from many centers use data from a multi-center registry to try and describe the incidence and pathophysiology of this complication. Now, they found the incidence was low, only 0.22% overall, but it was more common in valve-in-valve TAVR and if self-expanding valves were used. Women were more commonly affected than men, and also noteworthy is that these patients have a high rate of serious complications. It was bad to have delayed coronary obstruction. For instance, 1 in 3 patients who had it presented with cardiac arrest. Now, the paper has a lot of technical details about distances from the left main, etc. And the authors suggest, importantly, that the incidence of this complication may be an underestimate because of voluntary reporting in the registry. My take-home of this issue is one that I've expressed often about TAVR. The complications from the procedure, and those that are specific to TAVR, take on special importance when we consider doing this to lower-risk patients. So when someone can't have a SAVR because they're super high risk, TAVR is a great option. But when intermediate or lower risk patients are considered, these sorts of complications take on additional importance. Also important here is that there's this notion that there's no worries about lower rates of valve longevity. Why? Because when the first TAVR valve wears out, you can just have a valve-in-valve TAVR. Now, not only does that seem foolish just from a common sense standpoint, but also in this study, the rate of delayed coronary obstruction, a serious complication, was significantly worse in valve-in-valve TAVR. Now, make no mistake, I am pro-TAVR. I love TAVR, but we will have to be careful to temper our tendencies for over-exuberance of that which is new. We love things that are new in cardiology, but again, it's important not to be over-exuberant. So that's it for this week in cardiology. I'm glad that you listened. I'm grateful. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.